Welcome to Wednesday Night Study Live, where we gather together to study for addiction counselor exams. Tonight's study guide video, tonight's video topic is opioid use disorder and other opioid topics. Welcome, come on in. Make sure you like the video and make sure you're subscribed so you never miss a weekly study video. If you're new here, welcome. Welcome to our learning community. I'm Letitia, a licensed professional counselor and licensed substance abuse treatment practitioner. By day, I'm a therapist, educator, trainer. By night, I'm your study partner. I post addiction counselor topic study videos to support you in passing your addiction counselor exam. So if you are watching, preparing for an addiction counselor exam, in an addiction counselor class or counseling program, or you're interested in starting a career as an addiction professional, you're in the right place. We're not studying for a specific exam, but our study partners have passed the ADC, the AADC, the MAC exam, the NCAC1, the NCAC2, and several certifications based all over the country. So we focus on mastering foundational addiction counselor exam topics. So that's how all of us are able to pass and study and successfully pass different types of exams. So welcome again. Make sure you subscribe so you can join us every Wednesday live. And even if you can't join us live, you can watch the playback. Hello to the playback. Thank you for joining us. Thank you for watching. We know you're busy. We know you're working. We have lots of actively working clinicians in our community, so I know how it is. As long as you review your questions so you can get your study time in, no worries if you can't join us live. So hello to the playback. Let me go over to the chat to see who's in here. Good evening, good evening. Hello, hello, hello. Thank you for joining. I hope everyone is well. If you can put a 1 in the chat if you can hear me clearly, so I can go ahead and get started on our study questions. So hopefully we have a good, clear Wi-Fi night, you guys. Thank you so much, Jessica. Hello, Colette. Thank you. Thank you, Juan. All right. I'm glad I'm nice and clear. Thank you, Bobby. For anyone who needs additional study resources, I've put the link in the description, also in the chat. So after the video finishes, you can go over to my stand store. I have 3 resources. The first resource is a free resource. It's a study guide. The second resource is a 100-question practice test. You use it to simulate exam settings. So you find a quiet space and you answer all 100 questions. And then the third resource is a study guide checklist. That's the more detailed checklist. It's, I think, 67 pages, 68 pages, where I break down study topics and give you a checklist so you can have a more guided way of seeing what topics you need more study time on, what topics you've already mastered. All right, let's get started, you guys. Okay, welcome again, study partners. We're going to review 10 practice questions this evening, study questions that are focused on opioid use disorder and other opioid topics such as medications, overdose symptoms, and things like that. We review these questions and these foundational topics so that we have a better understanding of foundational addiction exam topics. I will read each question, pause. You will put your answer in the chat. And then I reveal the answer, and then I have explanations that I read out to help you better reinforce the knowledge. Right. Let me turn my camera off. Make sure All right. Our study live topic again is opioid use disorder and other opioid topics. As I stated last week, for the next couple weeks, I'll focus on disorders and disorder topics. That's like the number 2 requested topic. The first most requested topic is pharmacology. I'm working on a video series for that, Pharmacology Basics. We'll be working through questions that touch on opioid use disorder, withdrawal, overdose, medications used in treatment, and other opioid related concepts that may show up on your exam. So we don't know exactly what they're going to ask, but we know for foundational knowledge as an addiction counselor, we all need to be familiar with disorders, substance use disorders, and opioid use disorder and opioid topics. So again, as addiction counselors, our scope of practice is not prescribing, but we do need to have a solid knowledge of medications our clients may be prescribed or may be using due to a substance use issue or disorder. I sent this graphic with the reminder. So even if you're not interested in the resources, if you're interested in receiving emails and reminders, I send an email maybe once a week. You can download the free study guide, and that places you directly on my email list. Before we jump into the questions, here are the main opioid related areas you want to keep in mind for tonight's study live. These are the topics that often show up in some form or one way or another on addiction counselor exams. This will help you frame how you think about opioid related questions. First, you want to know common opioids. So that includes substances like heroin, morphine, oxycodone, hydrocodone, fentanyl, and so on. You don't have to become a pharmacology expert, but you do want to be able to recognize common opioid names and understand that some are prescribed medications, some are used in treatment, and some are associated with high overdose risk. Secondly, you want to know the diagnostic criteria for OUD, opioid use disorder. That means understanding the general DSM-5 substance use disorder patterns like impaired control, craving, social or occupational problems, risky use, tolerance, and withdrawal. Some questions on your addiction counselor exams may ask you to identify signs that fit an opioid use disorder diagnosis or to determine the severity of an opioid use disorder. Make sure you can tell the difference between withdrawal and overdose. Opioid withdrawal is often deeply uncomfortable and may include symptoms like muscle aches, sweating, nausea, diarrhea, yawning, and anxiety. An overdose, on the other hand, is a medical emergency and may involve slow breathing, pinpoint pupils, unresponsiveness, and blue lips or nails. On your exam, you need to be able to recognize which situation is being described and what response is most appropriate. You also want to understand common opioid medications that come up in treatment. This includes medications like methadone, Suboxone, naltrexone, and naloxone. You do not need to know every medical detail, but you should understand the basic purpose of each and how they relate to treatment. And finally, you want to be familiar with evidence-based treatments for opioid use disorder. That includes medication treatment, counseling approaches, and relapse prevention strategies. All right. So for me, for opioid use disorder, remember, I'm a visual learner. So I will put opioid use disorder like in the circle, and then I would put tentacles around opioid use disorder, and I'll put MAT. The first thing that comes up for me when I think opioid use disorder is medication assisted treatment. Not to say that every person who's diagnosed will need medication, but for your addiction counselor exam, Typically, that is going to be the evidence-based intervention that almost always comes with opioid use disorder. Some type of medication assisted treatment, which includes medication, therapy, maybe some type of inpatients like that. Also, I think of the intense withdrawal symptoms. So be familiar with the different withdrawal symptoms that each drug has. Okay, let's get into the questions. Question 1. Which of the following is not a medication commonly used to treat opioid use disorder? Buprenorphine, methadone, naltrexone, or oxycodone? Which is not a medication commonly used to treat opioid use disorder? Okay. All right. C, D. Juan has a D. Jessica answered D. Bobby answered D. The correct answer is D, oxycodone. D is correct because oxycodone is not a standard medication used to treat opioid use disorder. It is a prescription opioid used for pain management and is one of the opioids commonly associated with misuse, dependence, or overdose risk. A is incorrect because buprenorphine is a medication used to treat opioid use disorder. It helps reduce cravings and withdrawal symptoms and is commonly prescribed as part of opioid use disorder treatment. B is incorrect because methadone is a medication used to treat opioid use disorder. It is a long-acting opioid agonist used in structured treatment settings to reduce cravings, withdrawal, and opioid misuse. And C is incorrect because naltrexone is used in treatment of opioid use disorder. It is an opioid antagonist that blocks opioid effects and may be used to support relapse prevention. So the correct answer is oxycodone. It's not a medication used to treat opioid use disorder. The other three are. Question 2. Which of the following is a synthetic opioid? Heroin, morphine, fentanyl, or codeine? Which is a synthetic opioid? Okay, Colette has C. Okay. The correct answer is fentanyl. Fentanyl is a synthetic opioid, meaning it is fully made in a lab rather than directly derived from the opium poppy. It is also much more potent than many other opioids and is commonly associated with overdose risk. A is incorrect because heroin is a semi-synthetic opioid, not a synthetic opioid. B is incorrect because morphine is a natural opiate derived from the opium poppy. And D is incorrect because codeine is a natural opiate derived from the opium poppy. So think fentanyl, very potent, synthetic. Usually synthetic things are much more potent for our body because it's not natural. Question 3. A client continues using opioids despite cravings, unsuccessful attempts to cut down, and ongoing problems at home related to opioid use. These symptoms are most consistent with A. Opioid intoxication, B. Opioid overdose, C. Opioid use disorder, or D. Opioid withdrawal. Client is using opioids despite cravings, unsuccessful attempts to cut down, and ongoing problems. These symptoms are most consistent with, oh, I'm sorry, guys. I gave y'all the answer. Sorry, y'all. It's been a long day, guys. But the correct answer is C, opioid use disorder. Opioid use disorder involves problematic pattern of opioid use that leads to clinically significant impairment or distress. Signs can include craving, unsuccessful efforts to cut down, continued use despite social or interpersonal problems, tolerance, withdrawal, and using more than intended. In this question, the client's cravings, inability to reduce their use, and ongoing problems point to opioid use disorder. Also, when you're reading your exams, take your time, read your questions carefully, because remember, some people are prescribed opioids for pain management. So something that I did when I was first studying for the NCAC 1, I always connected opioid use to immediately opioid use disorder or opioid abuse, when that's just not true. Some people use opioids for pain management. So make sure your question, you're clear on what they're asking you, and you just don't jump straight to opioid use disorder. They have to meet criteria. Question 4. Client A presents an active opioid withdrawal. Why is routine outpatient therapy alone not the most appropriate level of care at this time? A. Outpatient therapy focuses mainly on long-term coping rather than immediate withdrawal management and medical monitoring. B. Outpatient therapy is only appropriate after a client has completed inpatient treatment for opioid use disorder. C. Outpatient therapy cannot be used when a client reports cravings, discomfort, or fear related to opioid withdrawal. Or C. Outpatient therapy is designed for clients who misuse stimulants or alcohol rather than opioids in withdrawal. So client is in active withdrawal. Why is outpatient therapy not the most appropriate level of care at this time? Okay, I see A. Okay, I see lots of A's. Anybody think it's anything else? So this question will fall under understanding opioid use disorder, understand opioid withdrawal, and it will also fall under level of care. So understanding what level of care matches to the client's needs and symptoms. All right, I see lots of A's. The correct answer is A. Outpatient therapy focuses mainly on long-term coping rather than immediate withdrawal management and medical monitoring. When a client presents an active opioid withdrawal, the immediate concern is not just counseling. It is also safe withdrawal management, medical assessment, symptom monitoring, and stabilization. Routine outpatient therapy may be helpful later, but alone it does not provide the level of support needed to manage active withdrawal symptoms or monitor for complications. The client may need a higher level of care depending on severity and safety concerns. So again, when you're reading your question, your first question to yourself is, how do I keep this client safe? What answer is the safest an ethical answer to keep the client safe. And usually, where you have any type of medical or withdrawal symptoms, you're going to refer out, or it's going to say something about seeking medical attention, some type of higher level of care. Question 5. Which of the following is considered an evidence-based treatment approach for opioid use disorder? A. Weekly outpatient counseling focused on triggers, stress, and coping skills without discussing medication options. B. Medication-assisted treatment combined with counseling, relapse prevention, and ongoing recovery support. C. Short-term detox followed by discharge once withdrawal symptoms improve and the client feels more stable. And D. Motivating the client to stop opioid use immediately before exploring medication, referral, or withdrawal support. Which of the following is considered evidence-based treatment, an evidence-based treatment approach for opioid use disorder? And yes, the answers got a little wordy, guys. I had to make it a little bit more challenging. So which is the evidence-based approach? Okay. Okay. The correct answer is B, medication-assisted treatment combined with counseling, relapse prevention, and ongoing recovery support. Evidence-based treatment for opioid use disorder often includes medication-assisted treatment along with counseling, relapse prevention, and ongoing support. Medications like Suboxone and methadone are some of the medications commonly used in treatment to help reduce cravings and withdrawal symptoms. The strongest answer is the one that combines medication support with counseling and recovery-focused care rather than relying on counseling alone, detox alone, or motivation without a treatment plan. A is incorrect because weekly outpatient counseling focused on triggers, stress, and coping skills without discussing medication options would be incorrect. So counseling is vital, is a vital part of treatment, but for many clients with opioid use disorder, counseling alone is not the most evidence-based approach. C is incorrect because short-term detox followed by discharge once withdrawal symptoms improve is incorrect. Detox alone is not considered sufficient treatment for opioid use disorder because clients remain at high risk for relapse and overdose without continued treatment and recovery support. And D is incorrect because motivating the client to stop opioid use immediately before exploring medication is not an evidence-based response for opioid use disorder. So even if they choose not to use medication, it should be a part of something that they're offered and educated on. So when you think opioid use disorder, evidence-based usually is going to lean towards some type of medication-assisted treatment or education, or at least one of their options. Did I skip I guess it's supposed to be 6. I have 2 number 5s, but let's just go with it. Naloxone is best described as A long-term medication used to reduce opioid cravings and prevent withdrawal symptoms. B, a counseling intervention used to help clients process triggers related to opioid relapse. C, A medication used to reverse the effects of an opioid overdose in an emergency. Or D, a maintenance medication that blocks cravings and is taken daily for opioid use disorder. Which one best describes naloxone? Naloxone. Sorry, guys. Y'all know I get tongue tied. So this is question 6. Okay, we got C, we got a D. The correct answer is C. Naloxone is an opioid overdose reversal medication. It is used in emergency situations when a person is experiencing an opioid overdose, especially when there are signs such as slow or stopped breathing. Naloxone can temporarily reverse opioid effects and help restore their breathing, but emergency medical follow-up is still required. A is incorrect because this describes medications used in ongoing treatment such as methadone or Suboxone, not naloxone. B is incorrect because naloxone is a medication, not a counseling intervention. And D is incorrect because naloxone is not a maintenance medication for daily opioid use disorder treatment. It's used for overdose reversal, not ongoing craving management. Question 7. Which of the following best describes how opioids affect the brain? They increase alertness and speed up central nervous system activity, leading to increased energy and rapid speech. B, they activate opioid receptors involved in pain and reward, which can reduce pain, create euphoria, and slow breathing. They primarily block all dopamine release, causing immediate confusion, panic, and severe perceptual disturbances. Or D, they stimulate the brain stress response system, causing hyperactivity, elevated body temperature, and intense agitation. Which one best describes how opioids affect our brain? Okay. Okay. I see some B's. The correct answer is B. They activate opioid receptors involved in pain and reward, which can reduce pain, create euphoria, and slow breathing. Opioids affect our brain by activating our opioid receptors, especially in areas involved in pain relief, reward, and breathing regulation. This can lead to reduced pain, feelings of pleasure or euphoria, sedation, and slow breathing. The slow breathing part is especially important because it helps explain why opioids can be so dangerous and have higher instances of overdose. A is incorrect because this is more consistent with stimulants, not opioid effects. Opioids generally slow the central nervous system rather than speed it up. C is incorrect because opioids do not primarily work by blocking all dopamine. And D is incorrect because these effects are not typical of opioids and are more in line with stimulant intoxication or severe withdrawal from other substances. So come up with a way to remember how opioids affect our brain and what physical and physiological effects is most related to opioid use. Question 8. Which of the following medications is classified as an opioid antagonist? A. Methadone. B. Naloxone. C. Oxycodone. Or D. Buprenorphine. Which one is an antagonist? Okay. So that's another thing you should know. The difference between an antagonist and an agonist. I think we had one of these questions a few lives back. Right? Which of the following medications is an opioid antagonist? The correct answer is naloxone. An opioid antagonist is a medication that blocks opioid receptors and can reverse or block opioid effects. So the way I remember, because remember, I'm a person, I need to break it all the way down. I need to learn like a fifth grader. So I won't overwhelm myself. I think of an antagonist as like your enemy, something that blocks you, a hater. So an opioid antagonist blocks the effects of the opioid completely, knocks it out, pow, pow. That's the way I remembered it. But maybe you can come up with a creative way or a way you can remember it so you don't overwhelm yourself. Naloxone is an opioid antagonist most commonly used to reverse opioid overdose in an emergency. It does not treat cravings or serve as a routine outpatient counseling support. It is used for overdose reversal. So it immediately knocks the effects out, boom, boom, to save the person's life. A is incorrect because methadone is an opioid agonist. Not antagonist, but agonist, used in treatment for opioid use disorder. Not an antagonist. Excuse me, guys. I forgot to turn my watch off. C is incorrect because oxycodone is an opioid pain medication, not an antagonist. And D is incorrect because buprenorphine is a partial opioid agonist, not an antagonist. Now, just even listening to that sounds a little confusing. But, okay. Question 9. Which of the following statements about heroin is most accurate? A. Heroin is a synthetic opioid commonly prescribed to manage moderate to severe pain in outpatient settings. B. Heroin is a semi-synthetic opioid that can produce euphoria, respiratory depression, and a high risk of dependence. C. Heroin is an opioid antagonist used to block opioid receptors and reverse overdose symptoms during emergencies. Or D. Heroin is a medication-assisted treatment used to reduce cravings and stabilize clients with opioid use disorder. Which is most accurate about heroin? Okay. All right. I see a lot of B's. All right. The correct answer is B. Heroin is a semi-synthetic opioid that can produce euphoria, respiratory depression, and a high risk of dependence. Heroin is a semi-synthetic opioid derived from morphine. It affects the brain's opioid receptors and can produce euphoria, pain relief, sedation, and slow breathing. It's also associated with a high risk of dependence, overdose, and opioid use disorder. For your exam, heroin is important to know as a commonly misused opioid rather than a treatment medication. A is incorrect because heroin is not a synthetic opioid and is not a prescribed pain medication. C is incorrect because this answer describes naloxone, not heroin. And D is incorrect because heroin is not a treatment medication. Medications such as methadone, Suboxone, and naltrexone are more relevant to treatment. Question 10. Which of the following situations places a client at the greatest risk for an opioid overdose? A client reports ongoing cravings, increased stress, and difficulty using coping skills during the first month of outpatient treatment. B, a client continues opioid use several times per week while minimizing concerns and declining recommendations for added support. C, a client resumes opioid use after a period of abstinence, increasing overdose risk because a opioid tolerance may be reduced. Or D, a client experiences repeated urges to use opioids when exposed to conflict, grief, and peers who still misuse substances. Which situation describes a client at the greatest risk for opioid overdose? This question tests your understanding of tolerance, risk, and opioid use. Okay. Okay, I see C. I see a D. The correct answer is C. The client who resumes opioid use after a period of abstinence increases their overdose risk. They're at the highest risk. And remember, for your exam, distinguish the difference between risk and it definitely happening. You might get a question about increased risk or decreased risk depending on certain factors. So think of it as a higher chance of something happening. A major risk factor for opioid use overdose is returning to opioid use after a period of abstinence. After detox, incarceration, residential treatment, hospitalization, or even a period of reduced risk, a person's tolerance can drop. If they return to using the same amount they previously used, that amount may now be too much for the body to handle, significantly increasing overdose risk. So this also can be a question on your knowledge of care coordination, aftercare treatment, things like that. Like understanding that a person can be in a 30-day, 60-day, 90-day treatment, they're doing well, but actually they're at higher risk when they leave, so they need that extra support. So some people not in the field may be like, no, they're doing great. Someone who's not an addiction professional would say, no, this person has been in treatment for 90 days. They're doing great. They're not at risk. They're ready. But we as addiction professionals know they need continued support, aftercare support, so that because they're at higher risk. Doesn't mean they'll definitely go back to using, but if they do use at the same amount, it can be deadly. Okay, A is incorrect because this does not suggest relapse risk and a need for support, but it's not as directly associated with overdose risk. So a client having cravings and having stress and not being able to cope is not this client situation in A is not at the greatest risk. B is incorrect because continued opioid use is concerning and can be an issue, but the question asks for which situation has the greatest risk. And D is incorrect because this situation describes triggers and relapse vulnerability. So this client may be vulnerable, but not at the greatest risk out of the four. Okay. All right. So our key takeaways for tonight. First, make sure you know common opioids. You should be able to recognize names like heroin, fentanyl, oxycodone, morphine, methadone, Suboxone, and naloxone. You should also be able to understand which ones are commonly misused, which ones are used in treatment. So again, just come up with easy ways that can trigger your memory. Don't try to overdo it. We're not in pharmacology school, but we do need just the basic understanding of the common medicines and medications and substances that our clients may use. Second, understand how opioids affect our brain. They act on our opioid receptors in the brain and body, especially areas related to pain, reward, and breathing. So again, to go back to my visual picture, I will put opioid use in the middle, and one of the tentacles would be pain receptors, because opioids are actually prescribed as pain medication, but they also affect our pain receptors when they are abused also. They can reduce pain and create feelings of pleasure, but they also slow the nervous system, aka slows your breathing down, which makes it dangerous, because if you take too much, it'll slow your breathing till you're not breathing anymore. Third, make sure you understand the criteria for opioid use disorder. You don't have to memorize every single criteria word for word, but you do need to recognize the overall pattern of problematic use. What I do is get your DSM-5 or download a quick sheet online and make sure you know the 11 or 12. Just have the foundation. Now, some substance use disorders have different nuances, but if you remember those 11 criteria, you should be good for your exam. Problematic use, increased tolerance, problems completing daily skills, and decrease in functioning. So just come up with quick ways to remember criteria for disorder use. Next, understand opioid withdrawal and opioid overdose. What are the signs? Have knowledge of naloxone. I think the name brand is Narcan, right? But Narcan is naloxone. It reverses overdose symptoms. So understand what it's used for. Connect MAT, medication assisted treatment, as a evidence-based intervention for opioid use disorder. They go together like peanut butter and jelly for the exam. I'm not saying every person who's diagnosed with opioid use disorder is definitely going to take medication, but for your exam, remember, we're in a perfect world. We're going by the book. They're like peanut butter and jelly. That's one of the evidence-based interventions because they've done lots of lots of research, and they find that people who get both medication, counseling, prevention services, the wraparound, are more likely to stay in recovery when they have opioid use disorder. So MAT and opioid use disorder are like peanut butter and jelly. And lastly, remember, reduced tolerance increases overdose risk. So have an understanding of tolerance, just the basic definition of tolerance, but specifically for opioid use disorder, it's going to put your client at the highest risk. All right, guys. Got a few more minutes. All right. So while we're waiting, is anyone scheduled to take their exam within the next couple weeks? No problem, Juan. Juan says, thank you so much. I can't wait for pharmacology. In August, I'm doing August is going to be a little bit different. We're doing the intensive sessions because I'm preparing for recovery month. So on Wednesdays in August, not July, Wednesdays in August, I'm doing 6 to 9, and I'm doing those extended sessions because, one, for those of you who can hang out for 3 hours, it'll give you an idea how long 3 hours is. But also, it gives I get a chance to do longer intensive sessions in preparation for recovery month because I know people are going to be looking for information on addiction, substance use recovery. And instead of doing it actually in recovery month, we're going to do it early. So we're going to have the same schedule through July, but the first Wednesday in August, we're going to do 6 to 9. Hopefully you guys can join me. But if not, you can stay an hour, then log off, or you can stay the full 3 hours, and it's going to be split up into topics. So hour one will be one topic, and it's going to be the most important, the most requested topic. So let's say hour one might be pharmacology. Hour two might be medications. Hour three might be counseling techniques. And then that way, for Addiction Recovery Month, we already have 4 extended videos for people who want to learn about addiction counseling, substance use. So I am already preparing for that. But that's not until August, you guys. The next couple weeks, we're still going to do Wednesday, 7 to 8. I'll keep you guys posted. Thank you, guys. Thank you. I'm going to stay on to 8 o'clock. So let's go over frequently asked questions. Hi, Marie. So this week, same frequently asked question. Is this good for IC and RC? I would say yes. And I asked specifically what exam you're taking. So To my knowledge, the ICNRC exams are the AADC and the ADC. Yes, we've had study partners pass the ADC and AADC. Second asked question this week, they were asking about prices of didactic courses or your substance use courses. So if you're listening and you're not an addiction professional, you're interested in the career, maybe you don't have a college degree, or you have a college degree that's a non-clinical degree, so a degree outside of psychology, counseling, social work, human services. I'm in Virginia. Typically, we have a set amount of courses that you have to take before you can do your internship or your residency. So if you are watching, I would say go to your state board of counseling, or whatever your state calls it. Sometimes they call it a board of counseling. Sometimes they call it, they have other names for it, but start there so you can know exactly what you need to transition into our profession. Typically, you're going to be required to have some type of psychology, counseling, clinical courses in order to set your foundation. So that was the question this week. So if you're interested in becoming an addiction professional, Google drug counselor, then put your state, or addiction counselor, put your state. So if you're in Michigan, go to Google and say alcohol and drug counselor, Michigan, and all of that will come up for your state. Hi, Marie. Hi, Marie. I got your comment before. Thank you so much for your service. I know you have a wealth of knowledge. Please continue to visit us and drop down in the comments and give us support and tips. Thank you so much for joining us. Marie is a retired licensed addiction professional. She has the MAC credential. So yes, and hello to the playback again. We haven't forgot about you. We haven't forgot about you, playback. And those were the two questions this week that I answered. So yeah, interested in the field? Go to your local board of counseling. Next week is going to be stimulant use disorder, cocaine use disorder, and stimulant topics. Juan says, Letitia, what is your thoughts on Momatrex text preparation? I used Momatrex when I took the NCAC one in 2016. I was looking up some videos, some came up. Now remember, this was in 2016. But I bought the alcohol and drug counselor Momatrex book. So I think they're a solid resource. Yes, it is, Marie. Marie says substance abuse field is an amazing field to be in. Yes, very, rewarding, constant learning. I love that I'm always learning because no one client is alike. So if you love learning and building your knowledge, it's always going to be something new. So yeah, Juan, I used the Momatrex and I thought it was helpful. I will say this, for those of you who are in the beginning of your study journey, don't pressure yourself to buy things yet. Use what you got first. So, first of all, you got the internet. Now, I know the internet can be a wild, wild west, but this is why I'm doing these video playlists so we can have our part of the internet where you can just learn and review, and it can be, accurate information from our learning community, which includes clinicians. Most of us are actively working in the field. So most of our information, if not all, is going to be accurate. So use the internet first if you're just starting your study journey. Don't feel pressured to buy things because you don't have to. Um, I always say use the internet, watch videos, find those free study practice tests. There we have a lot of exam prep on YouTube. Then figure out your areas of need. If you have one or two topics where you feel like, oh, I just couldn't get it. My area was medications. I worked in community mental health for years, but I didn't have clients who per se took medications. I did more family work, adolescent children work. So that was my area where I needed a little bit more practice, and that's how I ended up purchasing the Mama Treks book. So I would say use up all of your free resources first, then decide on your one or two study, resources that you want to purchase. That way you don't pressure yourself to spend so much money. Unless you're rich. If y'all rich, great. Go ahead, buy it up. But I was looking at the grocery prices last week and I was like, maybe we can eat air. Because everything is expensive. So yeah, Mama Treks is good. I've seen a few resources. Yeah. And then don't forget, once you continue in the field, you still got to buy your DSM-5. You got to stay updated with your, I have, like I was showing y'all the other week, I still have to purchase the new ASAM book. I have the old ASAM and then I have the new download, but I want to get the hard copy. So it can get quite expensive. Then your certifications, I don't mean to be a Debbie Downer, but anybody recertified, I had to recertify my licenses. It was a pretty penny. So save as much money as you can. But yeah. So yeah. But again, thank you guys for joining me. Per usual, if you have any questions, feel free to put them on the comment section. I check my comments at the end of the evening every day. I want to make sure I stay tapped in with you guys. Marie says, I recently recredentialed my license in North Carolina and Georgia. So do you plan on like doing part-time work, Marie? Or you just keep them up just in case? How does that work? I'm really interested because I know some people, when they retire, they like keep it active just in case they want to do some part-time work or in case they want to get back out there. And when I was looking at my recredential, it asked me, okay, Marie says, I'm fully retired, but I maintain my credentials. Awesome. Okay. Juan says, I've been a group facilitator at the facility I work, so I am rusty on counseling. I do have an associate's degree in alcohol and drug addiction, but I need to become certified. Awesome. Okay. Awesome, Juan. Yeah, it happens because remember, that's why I say when we're taking our exams, think about a perfect world because we're active clinicians, we know we know our job, and then we also know how realistic we know the reality of addiction work. And sometimes that can be overwhelming if we think too much about the reality of addiction work and then a perfect world, like a perfect textbook world. So yes, we're going to become rusty in certain areas because we don't work in all areas, and that's okay because we're lifetime learners. When we become clinicians, we agree to be lifetime learners because again, every client is different. So that's okay. And you're going to be fine. Just figure out which areas you're rusty in and keep it moving, learn. Like for me, again, the reason why I was so rusty in the medications part and the opioid use part because I didn't work in that area. a lot of my work was marijuana use, adolescent use, family interventions, community mental health. That's my jam. So when I started studying, I immediately knew I need some extra. I need extra study time in um, like medication management, medication treatment, opioid use disorder. I need extra time in that area because that's not my strength. Okay, guys, make sure you like the video. And if you're not subscribed, make sure you're subscribed so that other study partners can find us. We have study partners all over the country. We're like over 2,500 study partners strong right now. And that's because of you commenting and liking and sharing the videos. They have been so helpful. And it helps other people studying for their addiction counselor exams or other addiction professionals. It helps us find each other. So thank you so much, you guys. Have a wonderful evening. I'll see you next week.